Cannot hear.
Good evening, Dr. Muhammad. We couldn't hear your voice now. Is it okay, the others?
He is not speaking, Marwat.
Okay, now you can hear me?
Yeah, we can.
Okay.
Yes,
so,
yes, we can now. Thank you, Dr. Babu.
Okay.
So we will start. Okay, so if you want to speak, housekeeping rules, if you want to ask a question, unmute yourself and speak up, or you can stay unmuted. But if there is, in your, voice in your environment, then please mute yourself. Okay. And you can use the chat. Okay.
You can use the raise hand also.
Yes, raise hands also. Okay.
Yeah.
But you stay unmuted if you are, because I want some interaction. Stay unmuted if your environment is quiet. Okay. Okay. So I'll start. Okay. So we did talk about a couple of things last 2 weeks ago, and just a refresher. Okay, because it was a little bit.
Muhammad, can you make? Yeah, that's good. PowerPoint bigger.
Okay.
Yeah.
So, if you remember, last I have to admit, just a second. I have to admit people. Last conference. Okay, here. Every time someone joins, I have to admit him. So that's a little bit annoying. Okay. So last conference we talked about risk factors for hypertrophic cardiomyopathy in terms of sudden death. Okay, and we said that if someone presents to you with either cardiac arrest and then survived, of course, or had sustained VT, then no brainer, we give them an ICD, right? However, if someone presents to you with hypertrophic cardiomyopathy, then the question is, when should that person get an ICD? And we reviewed many studies, almost all studies, in fact. And in adults, the risk factors are very well established. In pediatrics, though, it's not that well established, but severe left ventricular hypertrophy, especially the posterior wall, is a big risk factor. Otherwise, the rest is less of risk factors, but of course you have to consider them. And the other factors are when you have non-obstructive hypertrophic cardiomyopathy, not obstructive but non-obstructive. When you have unexplained syncope, you remember with hypertrophy they are prone to vasovagal syncope. So when you get someone with hypertrophic cardiomyopathy and he syncopizes or he develops syncope, you would want to get good history and make sure it's not vasovagal. So if it's indeed unexplained, then that's a risk factor, and you should think of primary prevention ICD. And if someone has non-sustained VT on ECG or on a Holter, and then there are newer risk factors such as late gadolinium enhancement on MRI and genetics as well that also are coming into play, but there are no pediatric studies yet for hypertrophic cardiomyopathy and for such risk factors. Okay, but remember these, and then at least if you need probably 2 of these to then implant an ICD, because we said in pediatrics there's high rate of complications from ICD and there's high rate of inappropriate shock, meaning shock delivered to a patient who does not have VT or VF. Because shock should only be delivered to VT or VF. Okay, if it's SVT or atrial tachycardia or sinus tachycardia, these are all inappropriate. Okay, so And remember, with pediatrics, people do tend to have higher heart rates, and the pacemaker may, or sorry, the ICD may confuse the higher heart rate with VT and inappropriately shock the patient. Okay, let me just accept Arwa. Okay. So also we said, so we talked about ICDs, and remember we said there is types of ICDs. There is epicardial, there's transvenous, there's subcutaneous. We talked about their advantages and disadvantages, so we will not repeat this. Okay. Also we said there is something called in WBW that is intermittent, which is in general a risk factor, which is in general implies that the accessory pathway is weaker and the patient is less likely to develop, rapid ventricular conduction when the patient develops AFib. But there are indeed patients with intermittent WBW and VF documented. So WBW, in general, people in general eventually needs ablation, okay? Because even intermittent WBW, there is some risk of sudden death, okay? So we talked about this. And then also we said that when you have a patient with cardiomyopathy, whether it's hypertrophic cardiomyopathy or dilated cardiomyopathy, sometimes there are syndromes that are that combine both WBW with the cardiomyopathies. And we mentioned a couple of syndromes. So, you may see WBW in addition to a cardiomyopathy patient on ECG. So that's very commonly associated. And we showed an example of a patient that we do have. The patient had DCM with WBW, and I showed an example as well. And then we also said there's something called adenosine challenge to confirm accessory pathway that is, supra, that is in the atrioventricular group. Remember, this is our drawing. So everyone can see my drawing, right?
Yeah.
Right. So remember, we said there are, the accessory pathways that we worry about are the pathways that are coming in the AV group. Okay. For example, here, because if someone develops AFib, it will rapidly conduct to the ventricle, and then the patient is prone to VFib, okay, and death. However, there are pathways that are below the AV node, okay. So let's say it's let's say from the just below the node to the fascicles, okay. These pathways are commonly associated with the cardiomyopathies, and but they are benign, because if this patient develops AFib, the patient is still protected from VFib because the AV node protects does not conduct 300 beats per minute and above from AFib, right? So the AV node always blocks the rapid impulses. So then the patient is protected from developing VFib, okay? So we have two different, WBWs or WBW syndromes, and to differentiate between the one that really matters is to give adenosine. So remember this, Babu, right? So we said,
yeah.
You give adenosine, and then what you will see enhancement of pre-excitation, because everything is going down the accessory pathway. So the baseline ECG, let's say, is this, okay? With adenosine, it becomes like this. This makes sense to everyone?
Yeah.
Right? So when you see a patient with WBW and you give him an adenosine, if you see the ECG changes so that the QRS is widening and there's more delta, then it's a true accessory pathway that is in the AV groove, which is the pathway that you worry about. Because why am I mentioning this? Because again, there are benign pathways associated with cardiomyopathies that are often, you often encounter them, and then you don't have to worry about ablating them, and you do this simple test. If you give adenosine and the ECG the QRS doesn't widen, remains the same, or there's an AV block, then it's one of those benign accessory pathways that you may not need to worry about, okay? And we said as well, let me show you this. This is an ECG. So remember, we said this is our patient with the DCM. So this is a patient with DCM, 4 years old, also has WBW, as you can see here, right? But then this patient develops nice junctional beats that are narrow. So this tells you the patient accessory pathway is indeed from the AV groove because you know, again, this is our drawing here. Okay, so the junctional beat means starts from here, right? So if you lose, and the accessory pathway is here. So if you have a junctional beat and there's no WBW, then you know the pathway is coming from above the AV node, from away from the AV node, right? So this tells you this phenomenon tells you that there are, and this patient accessory pathway is indeed in the atrioventricular groove. Makes sense to everyone? That was a little bit complicated, but so that's why I'm repeating it. Fair enough?
Yeah.
Yeah. Okay. So that's a nice ECG that, you know, this patient, you know, simultaneously had junctional beats that proved an accessory pathway being in the atrioventricular groove. Okay. And then it tells you that this patient accessory pathway may be important to ablate. Okay. It's also intermittent on other ECGs, so we know it's indeed it's important to ablate, but it's probably not very high risk accessory pathway. But one day we need, you know, we ablated it. It was, you know, by the AV node, but this patient also has genetic, you know, homozygous mutation for DCM, and his EF is not very good. So, you know, this patient is probably will need a transplant one day. Anyways, and I wanted to show you an example of adenosine challenge test. This was not available last time. So, you know, this patient had, this is his baseline ECG. And, you know, if you see the ECG, you wonder whether there's, you know, there is definitely delta wave, you know, hint of delta wave, you know, here. And, you know, here, that's a nice delta wave, right? You know, but that, you know, but people wanted to confirm. So the adenosine was given, and you see the QRS widening, right? You see enhancement of the delta wave and widening of the QRS. You see here, okay, yeah, with adenosine, right? So that tells you that this is true accessory pathway. This patient deserves an ablation one day. Okay, make sense?
Yeah.
Okay. Versus this patient, this is a hypoplast patient with an ECG that, you know, this QRS, short PR, there's a little bit of delta. And I mentioned that with cardiomyopathies, hypoplast being one of them, meaning, you know, you have like ventricular hypertrophy, usually with hypertroph. Then you wonder whether if there is an accessory pathway here, is it the true, you know, atrioventricular accessory pathway, groove accessory pathway, or one of those infranodal? And this patient, if you look at the rhythm strip, eventually is having an accelerated junctional rhythm. You know, here the P and the QRs are fusing. You know, you see the PR here versus the PR here is super short. So then this patient had accelerated junctional rhythm with similar QRS. So this tells you that the accessory pathway is infranodal because, again, our diagram here, so this patient developed a junctional rhythm with persistent pre-excitation. So this tells you that the accessory pathway is below the AV node. Make sense?
Yeah.
Yeah. So this is a true, you know, these are our patients. True example of patient with AV groove accessory pathway, which is the important one, versus accessory pathways that are infranodal, like nodofascicular, and many others that are they are in general benign. Okay. Okay. So, questions so far? Questions. I'm getting. I don't know whether people are sending. I'm not sure. I cannot see, by the way, your text, your chat, by the way. So if you have a question, please speak up. Okay. Or if someone else can read the questions and let me know, because I cannot see it.
You can have the message one pressed. No, then you will see that. If you click on the message one, if there is anything,
I lost this bar. You know, this bar with the message.
Yeah.
I don't see it. I don't know. But if you can see, Mr. Babu,
you can write and you can read it also.
Yeah. Are there any questions that you can see or no questions?
No questions.
No questions. Okay.
This meeting recording started, Adnan. So I'll just say hi, Mohammed, whether you can see it or not. Just see.
Okay.
Can you see that?
No.
Yeah.
Well,
yeah.
I know it's coming, but I cannot see it.
You press on that message, you know, on the bar. If you toggle, you'll see a bar. You will see the telephone.
I see it now. I see it.
Yeah.
Thank you.
So you saw hi, Mohammed?
In
the meeting chat?
Just a second.
You know, that near the raised hand, the next one is the meeting, in the chat.
I think
just
it's
press on
very,
that. You'll see.
Yeah, it's just very slow to come up. You press it, you to wait 5 minutes. Okay, I see it now.
Yeah,
okay.
yeah. So we can ask you a question, you can answer looking at that.
Okay. So, and then one last thing to say regarding last week, 2 weeks ago topic was that sometimes WBW may lead to cardiomyopathy because remember, again, the accessory pathway, the accessory pathway does cause some dysynchrony, right? Because there is, usually the atrial impulse goes to the AV node, and then you have nice septal depolarization, and then left ventricular and right ventricular depolarization. But when you have an accessory pathway, this is disturbed. You have an abnormal conduction somewhere in addition to the normal conduction. So the synchrony of the ventricles are deranged, and rarely, especially with septal pathways, rarely the WW itself leads to dilated cardiomyopathy. And when you ablate the WW, often the dilated cardiomyopathy regresses, okay? So that's why it's important, if someone with dilated cardiomyopathy and you see WW, it's important to know where is this accessory pathway coming from, and if it's a significant accessory pathway that's AV, from the atrioventricular groove, you would expect that this accessory pathway may be causing some dysynchrony, and when I ablate this accessory pathway, the dysynchrony goes away and maybe the function improves. Okay, so these are all the things that I want to say about WW. Any questions before we proceed? Okay, so I went fast because we already mentioned all these points. It just needs, it's good to re-mention them because they were a little bit confusing. Okay, so now let's just talk about Flecainide. Flecainide is commonly used antiarrhythmic drug. We use it all the time, and people do have questions sometimes, and it's good for people to understand the medication that they are prescribing. Okay, so Flecainide is class 1C, okay, meaning it's a sodium channel blocker, okay, and the sodium channel blockers are subdivided into 1A, 1B, and 1C. 1C being that, you think about 1C as a very strong, potent sodium channel blocker, okay, versus 1A and 1B, less potent sodium channel blocker, okay? So Flecainide is a very strong sodium channel blocker, okay? So as a result, if you remember from med school, your action potential, this is phase 0 when depolarization starts. Sodium influxes into the cell, remember? Okay, sodium usually rapidly influxes into the cell, okay? So as you can imagine, when you give someone Flecainide, if Flecainide is on board, it will prevent rapid influx of sodium into the myocyte, okay? As such, the action potential will change from sharp to like this, okay? So the phase 0 part of the action potential would change, and as a result, you will get different action potential looking, and on ECG, the ECG will differ because the ECG is like multiple action potentials or coming together. Okay, so if you have phase 0 slope slower, then the QRS would widen. Okay, because phase 0 is where QRS is represented. Okay, so this is where QRS is depolarization, phase 0 is depolarization. Okay, so if you have if you have normal action potential, you'll have a nice and narrow QRS, and if you have a slow action potential, you'll have a wide QRS. Okay, so with Flecainide, you expect to decrease the slope of phase 0, and hence the QRS would widen, and you have decreased conduction velocity. Like the depolarization is slowing, and hence the contraction and the synchrony of the contraction slows down. The conduction velocity slows down. Hence, Flecainide may cause myocardial depression. Okay, so Flecainide leads to abnormal depolarization, and often when you have significant abnormal depolarization, the repolarization also gets abnormal. Whenever repolarization is dependent on depolarization. When you have depolarization abnormality, immediately your repolarization would change. Okay, that's why when you have someone on ECG with abnormal depolarization, you don't comment so much on ST segment changes, QT interval, T-wave morphology, because they're all are abnormal because of the depolarization. It's very difficult to assess ST segment changes and QT interval when you have an abnormal depolarization. Okay, so this is an example of one of our patients. Pre-Flecainide, it's a baby, newborn. You have 40 milliseconds QRS width. Okay, after Flecainide, good like 3 per kilo dose Flecainide. It's not even very high dose. You definitely see widening of the QRS. You agree?
Yeah.
Everyone agrees.
Yeah.
And then the repolarization change. You see T waves are inverted versus here it was upright, and if you look super carefully, you may see ST segment changes a little bit. You may see QT changes a little bit, but this is again the main Flecainide ECG manifestation is widening of the QRS. Okay, and because unfortunately here we don't have Flecainide levels. This is your only means of measuring Flecainide in the system. Okay, so if you give a patient Flecainide, especially pediatrics, you always need to do an ECG. Okay, and if the QRS widens by 20-30%, usually that tells you there is a good amount of Flecainide in the system. So if you don't see QRS widening, then you can go up on the dose. But if there is 20-30% increase in QRS duration, then you probably should at least do a level and confirm the Flecainide level. But in Kuwait, we do have it, but in private. In our hospital, it's not possible to obtain Flecainide level. Okay, so when you see widening the QRS and you don't have Flecainide level, you probably should add something else, do something else, rather than just increasing Flecainide. Okay, because sometimes what happens is when you give so much Flecainide, ECG changes so much, such that you have widening of the PR prolongation, widening of the QRS, everything widens. And of course, the function, when everything is widening, again, we said the conduction velocity would decrease, and as such, there would be decreased function and myocardial depression, and patient may arrest on you if there is so much Flecainide on board. Okay, so I in fact saw 2 patients with Flecainide toxicity with such an ECG that they almost die. Okay. So Flecainide is a serious drug if you're not very careful with, and if a patient is given an abnormal or incorrect dose, then there might be very severe consequences from this. Okay, so you have to be careful with Flecainide. Okay. So how does Flecainide work? Again, we said it's sodium channel block. This is from nice concise book of antiarrhythmics by Dr. Flecainide, and if you remember from med school, sodium channel is composed of gates. Okay, there are 2 main gates in the sodium channel, M gate and H gate. Okay, so usually what happens is the M gate at baseline is closed and the H gate is open, and then depolarization arrives, and then the M gate opens and sodium influxes into the cell. Okay, and then when it closes, the H gate closes and prevents further sodium influx. Okay, however, when the patient is given, let me admit someone just a second. Okay, so when the patient is given Flecainide, these dots represent Flecanides. Okay, so when the patient is given a Flecainide, Flecainide bounds to the H gate. Okay, such that so initially after it binds, when it's open up, it opens with some restriction. Okay, so that when the depolarization arrives, the M gate opens just normal. However, there's baseline restriction from Flecainide such that the sodium influx is limited. Make sense?
Yeah.
Okay, so Flecainide acts on the H gate and just makes it doesn't open freely. Okay, just think of it this way, and then there's less sodium coming in. Okay, so when you have with Flecainide, what's tricky about Flecainide is when the patient is for some reason ischemic or acidotic or there's hyperkalemia, this binding even increases. Remember when I said Flecainide is very potent sodium channel blocker. If the patient, let's say, goes MPO, so an example I have was one patient who was on 5 per kilo per day of Flecainide, so a decent dose. And I mentioned this story before, and he was undergoing cath procedure. And in the cath procedure, it took long, and the patient was somewhat dehydrated and became a little bit acidotic. And post-procedure, the ECG went very bad, and the patient arrested, and the QRS was super wide. And then it's probably what happened is that during acidosis, the Flecainide potency increased as if you're giving extra dose of Flecainide. The patient was, they did not stop Flecainide because they were worried about arrhythmia induction during, catheter procedure, which is fair. But you have to be careful when someone is on Flecainide and he's prone to dehydration, acidosis, hyperkalemia, or even ischemia, then there is way more Flecainide on board, and then you are at risk of toxicity. Okay, so also at faster heart rate, the Flecainide in general is even stronger. So in pediatrics, their baseline heart rate is fast, so there is as if there is more potency for Flecainide compared to adults. Okay, so with faster heart rates, when the patient is acidotic, hyperkalemic, ischemic, Flecainide is even more potent. Okay, it's even more powerful drug. So you have to be careful. This is why in babies you have to be careful with Flecainide. Okay. Anyways, so Flecainide is absorbed well from the GI system and is excreted by the liver and kidney. So if you have someone with liver disease, kidney disease, then you have to worry about Flecainide toxicity and levels and stuff. Okay, and usually it is given. Of course, orally. There is an IV Flecainide that is used rarely. We do have it in Kuwait, by the way, but mainly Flecainide is used as a PO drug. Okay. And then in babies or in pediatrics in general, especially babies, infants, people like to use milligram per meter squared per day. It's obviously more calculations, because you have to, measure the body surface area of the patient, and then height. You have to have good, accurate height, and then weight, and then and then do the meter squared, and then measure the dose. So it's easier to do milligram per kilo per day, but often, if you want a better therapeutic doses of Flecainide, you probably should go with milligrams per meter squared per day. Okay, so in preemies usually people lower the dose a little bit. Okay, and in infants up to in newborns up to 4 months, you usually do BID or BD or twice a day Flecainide, but then beyond 4 months all the way till 8 years or so, you do 3 times a day, and then after 8 years or so, you do BD again. So it's a little bit confusing. Half-life of flecainide is long in babies, like, a couple of months old, and after 8 years old. Otherwise, it's shorter. Okay, so that's why, in general, I do BD, honestly, in general, because I don't like more than BD dosing in general because of compliance issues. But if you want to be scientific, from 4 months of age to 8 years of age, it should be TDS, or 3 times a day. Okay. Okay. So these are the dosages that are for you to know, but you can easily look it up. Okay. So, and because of all the concerns with flecainide, we usually admit them, especially babies, infants. Okay, we admit them. We, typically, ideally, you want to draw a level after this, before the 5th or the 6th dose, because this is when you reach, steady state. However, we don't have it again in Kuwait. I don't know whether in Saudi Arabia, people are joining us from Saudi Arabia. If you want to speak up, guys, those from Saudi Arabia, if your practice, flecainide practice is a little bit different, let me know so that we interact a little bit. But we don't have, levels, so we don't do this, of course. We usually do daily ECGs, and typically you want to do an ECG after the dose, and an hour or 2 after the dose, so that it's peak level flecainide, so that you see the QRS during peak and you see how wide it is. Okay. Because when you give a drug, usually it peaks and then troughs, right? So peak of flecainide usually 2 hours. So if you want to know the level, indirect measure of level of flecainide, you do ECG 2 hours after your flecainide dose to see how bad is or how good is your QRS width. Make sense? Okay. And no one is asking questions today, so either nothing is making sense or everything is making perfect sense.
It's okay. Going on.
Yeah. Okay. Okay. So, yeah, and then obviously after the 6th dose, usually you reach steady state. Therefore, there's no need to repeat levels unless there's something that changes. Okay. So again, if you have someone with flecainide at home, if mom tells you, he's having acute gastroenteritis, he's vomiting, he's having diarrhea, you always tell the family that, with flecainide, if he's prone to dehydration, acidosis, to stop the drug. Okay. I don't care if he develops SVT in this setting, because SVT is benignish and usually well tolerated and easily managed, but flecainide toxicity is very difficult to manage. Okay, so if someone tells you, you always tell the family, if when he's sick and stuff, don't worry about flecainide, stop it, make sure he's well hydrated. After he's eating well, then resume flecainide. Okay. Okay. So, again, you will see with ECGs, you will see QRS widening. Also, you will see PR, P wave widening and PR, prolongation, because everything, conduction velocity is all decreasing. So everything widens up a little bit. Okay. So we talked about this, and we said there is negative inotropic effect from the flecainide. So there is a concern with flecainide in patients with decreased left ventricular function. Okay, that's well-known concern. It came from this. So back in the day, Dr. Babu, you may remember this study.
Casted.
Yeah. Yeah, so CAST, there was a study back in the day in 1986. So what they did was, in adults, of course, when people develop MI, some of them tend to develop PVCs and VT from MI. Okay, so and then that VT, kills the patient. Okay, so they, someone noted that flecainide suppresses those VTs. Okay, so they said, okay, for people who develop MI and PVCs, then flecainide is a good drug of choice. Okay. However, with randomized controlled trial, and they found, yes, it suppresses PVCs, but it also led to other arrhythmias and death. Okay, so they within about 2 years from the study was discontinued, and they noted that class 1C, Flecainide and Encanide, another one, the patients who took Flecainide in the setting of MI, they actually were more prone to mortality. They had more mortality. So that Flecainide reputation got a little bit, affected in this setting. So in pediatrics, of course, we do have patients sometimes with decreased LVF, or patients who are developed, they have congenital coronary artery anomalies, and they may be prone to ischemia, or if they have decreased, EF, the concern is whether Flecainide is safe for such patients. There are papers that suggested otherwise, that said, for example, this paper is, they compared Flecainide to all other antiarrhythmic drugs for a wide variety of, of congenital heart disease patients, being complex or simple, and they did not see death to be different when they compared Flecainide to other antiarrhythmic drugs. The p-value was not significant. So in general, there is this concern in adults for sure. In pediatrics, it has not been shown, but people in general avoid Flecainide if you have decreased LV function, okay, because of the negative inotropic effect and this concern, okay? So I would not give Flecainide if someone is having decreased function. However, if you believe that the decreased function is secondary to VT or PVC or atrial tachycardia or SVT that is responsive to Flecainide, then you may argue, if I give Flecainide, arrhythmia would go away, function would improve, so then it's less of a concern, right? Makes sense? Okay, so if you believe, so you have two scenarios. You have one scenario that someone has decreased function, and because of the decreased function, someone develops atrial tachycardia or ventricular tachycardia, so that patient should not be given Flecainide. However, if you know a patient who had normal function one day and developed arrhythmia, and then the arrhythmia became incessant, and then the function decreases, this patient may benefit from Flecainide, because if the Flecainide is very good in suppressing the arrhythmia, then the function may regress and be back to normal, because the arrhythmia was the culprit, and then no arrhythmia, then the function may normalize. Make sense? Okay. Yeah. So Flecainide, sometimes you cannot tell. So if you cannot tell, you probably should avoid Flecainide. Okay. So Flecainide is that's why we don't use, in general, we don't use Flecainide left and right, because many of our patients has decreased function, and then we don't use it. Okay. So when do we use Flecainide in general? When you have SVT, PGRT is a good, Flecainide is a good drug for PGRT. If you have JET, congenital, because post-op JET, usually they are ischemic, they are acidotic, they are tachycardic. You don't want to give Flecainide in post-op patient, but congenital JET, Flecainide is a good drug. When you have WW, atrial tachycardia, and AFib, these are all good uses of Flecainide. Okay. Okay. So if you have VT and non-ischemic, again, ischemia is, Flecainide and ischemia do not go along. Okay. So non-ischemic VT, sure, Flecainide may be very useful. Okay. And remember, we had the patient, if you remember a couple of weeks ago, we had the patient with posterior fascicular VT, and they usually respond to verapamil, and also one patient we have had was on Flecainide, and he was also responsive. So Flecainide is good for non-ischemic VT. Okay. Okay. So Flecainide is also good for something called CPVT, which it's I don't know whether you guys are like heard of it before. It's catecholinergic polymorphic VT. It's a rare arrhythmia mutation where there is where the patient is prone to ventricular tachycardia during stress or activity. Okay, so actually we have one family that I'm aware of with CPVT. We just diagnosed this family like 2 weeks ago. Okay, so it's an interesting family. they were diagnosed with idiopathic VT. They were on the adult side, and then the kids were referred to me. And, I was suspicious of CPVT. We did genetics, and, long story short, genetics came back positive for CPVT. So now the diagnosis changed from idiopathic VT, meaning we don't know, to CPVT, and, prognosis is very different. And, it's obviously, we know there are specific things that you can do, and usually people do very well with CPVT if you do the right things. Okay, so we can talk about CPVT in one separate lecture. It's a very interesting disease, and we actually have one family with it, so we should probably talk about CPVT one day. But Flecainide is a good drug for CPVT. Okay, there is this channel that Flecainide inhibits that's abnormal or hyperactive in CPVT. So Flecainide is good. Okay, and then there's another disease called arrhythmogenic right ventricular dysplasia, where Flecainide is also good. Okay, so again, it's ventricular tachycardia with cardiomyopathy. Okay, so there is a noise. I don't know who is this. You guys hear the noise, right? Okay. Okay. So then Flecainide is also good so long QT type 3 and 7. Okay. So again, long QT. Everyone knows long QT, but but there are so many types of long QT. Okay. There's, I think, at least 14 types. So I lost count. There are so many types of QT. They are very, very rare. Long QT1 and long QT2 is the commonest, and then everything else is very rare. Okay, 3 is less common as well, and then 1, 2, 3 commonest, and then everything else is very rare. So long QT3 is Flecainide works well for it, and then long QT7. We actually also had one patient who just diagnosed long QT7. So we have interesting patients coming. So this patient was diagnosed just 2 months ago, 3 months ago from genetics. Okay, so good. So we can talk about long QT7 one day, since we have a family now, and we definitely have CPVT family, one family of CPVT, one family of long QT7 that I'm aware of. Okay, we don't have any family of ARVD that I'm aware of. I think the adults, usually the ARVD manifests later in life. So usually it's more in adults, but I know in our adults we do have a couple of families, but I don't have a pediatric patient with ARVD manifestations yet, and we do have probably one long QT3, but not yet confirmed. So we all all these diseases we do have them. They are not like unheard of. Okay, so they do exist. And lastly, Flecainide could be used to diagnose Brugada, because Brugada is a sodium channel mutation, loss of function of a specific sodium channel mutation. And then when you give Flecainide, which is a sodium channel blocker, it worsens the sodium mutation, and there's Brugada pattern on ECG. So when you give, so let's say you see someone with you're not sure whether it looks Brugada or not, you give Flecainide, the Brugada worsens, then this suggests actual Brugada syndrome. Okay, so it's a diagnostic test for Brugada. Okay, so these are the main Flecainide uses. Okay, questions?
Yeah, something coming up in the chat channel.
Oh, yeah. Can you read it up for me? Because I don't know if there's no easy way for me to look it up.
When you toggle, you get that bar underneath.
Yeah.
The third one from the last side. Press on that. Press on that.
Can you read it for me?
So it's what time need to see the effect on ECG from start dose? That you have said after 5 or 6 doses you have to check, isn't it, so?
The level before the 5th or 6th
level is 4 to 6 hours.
The ECG, we do daily ECG before 2 hours after the morning dose.
Okay.
For 3 days.
Yeah. For 3 days.
Yeah. Okay.
Oh.
Okay.
And otherwise,
Any other
something-
questions?
No other
Okay.
question.
Okay, so these are, we have guidelines, general guide for like primary arrhythmia syndromes or like genetic arrhythmias, and then you can see here with long QT, Flecainide is a class 2A, again for long QT3, mainly here, there's long QT3, okay? And then, for example, here for CPVT, Flecainide is class 2A as well, okay? So, these are definitely established even on guidelines that Flecainide use. And also Flecainide, we also use Flecainide for fetal SVT, okay? So it's a very good drug for fetal SVT. We usually start with digoxin if there's no high drops. When you have high drops, digoxin absorption is very limited, okay? So if you have no high drops, you usually start with digoxin, and then second in line is Flecainide. If you have high drops, you just start with Flecainide, okay? And then you can do other things, but Flecainide is also a very good drug for fetal SVT, okay? Okay, okay, so just precautions. Flecainide is not given in atrial flutter, okay? Or any intraatrial re-entry tachycardia. Remember we talked about something intraatrial re-entry tachycardia, meaning there's a macro re-entry or macro big circuit in the atria that is, that is tachycardic, that is arrhythmic, okay? So why is this? Because Flecainide, sometimes, because these circuits are usually, flutter, for example, usually very fast, okay? It's like 300, 350 beats per minute. So then the AV node usually conducts every other one or every third one. So then the patient is fine, okay? When you give Flecainide, what Flecainide may do is to slow the conduction in the flutter circuit or atrial re-entry circuit, because again, Flecainide works in the atria and in the AV node and the ventricles, works everywhere, okay? Such that it slows it down so that the AV node conducts 1-to-1. So meaning, let's say the flutter is 350 beats per minute, it lowers it down to, like, let's say 280, and then the AV node conducts 1-to-1 at 280, then the patient ventricular rate, instead of being 150 or 180, it goes to 280, and then the patient is very sick or arresting, okay? So Flecainide, you don't use it solo for flutter or intraatrial re-entry tachycardia. Makes sense?
Yeah.
So you will never see me, someone with flutter, I'll tell you, just give him Flecainide. I never do this, okay, because of this, okay? So again,
this is true for all class 1. It's so for quinidine also usually give, Hollandaise used to give digoxin and then give these drugs.
Yeah, but no one uses quinidine anymore, but except rare.
Yeah, all class 1 I thought is will produce this problem.
Right, but Flecainide, class 1C is very known to slow things, and patient is now predisposed to 1-to-1 conduction. Yeah. Okay. So it's like for PGRT. When you have PGRT, remember when we have PGRT, we said there is, if you remember, you have a slowly conducting accessory pathway, like from ventricle to atria, it's like an upside down AV node. Okay, so the SVT goes down the AV node, up the pathway, but the pathway is slowly conducting. Okay, so then it's incessant because it goes down the AV node slowly and then goes up the pathway slowly. So the AV node, when it goes up the pathway slowly, the AV node is ready to conduct the electrical activation downwards because it's recovered from the the circuit from the previous electrical activation. So that slowing makes it tachycardia incessant. Okay, so with Flecainide, it sometimes, if you don't give an high enough dose before it works very well, sometimes it worsens the SVT because you just need higher dose, you just need more slowing to abort the SVT. So sometimes with Flecainide, that's why we admit them again. Sometimes Flecainide, it worsens the SVT, just makes it incessant, slower, but makes patient always in SVT. So you have to give more and more and more Flecainide, or you give something else. So with Flecainide, sometimes it definitely lowers your tachycardia, but it makes it more persistent. Okay, So flecainide, you have to make sure this doesn't happen with your specific patient, okay? If it happens, then you have to go up on the flecainide dose, up and up and up, or add something else to the flecainide, okay? So again, flecainide may convert, straightforward SVT into slower, incessant SVT, okay? And then patient is prone to tachycardia-induced cardiomyopathy. And if you have a patient, with a pacemaker, flecainide also may increase your threshold of capturing. So the pacemaker may require more voltage, battery depletion sooner, okay, quicker, okay. So we said this, and then when babies, when your mothers give flecainide and mix it with milk, it tends to decrease the GI absorption, okay? So meaning, you get less effective flecainide, dose, and which is usually fine, but it's sometimes, you have to go up and up and up to counteract this. And more importantly, flecainide, what we do is that, we tell the family to crush the pill, dissolve it, and then give it, right? And flecainide doesn't dissolve very well in general, okay? So such that there is usually, so that's your bottle. There is usually precipitates of flecainide here, and then more fluid here, okay? So when the mom is giving flecainide, if here, when it uses the upper part of the container, there's less flecainide, and then when it reaches the lower part of the container, there's suddenly highly concentrated flecainide, okay? So that's why you always want to shake the flecainide, suspension that you made very, very well before administering flecainide, okay? So tell moms, shake very, very, very well, okay? All the time. Before every dose, you have to shake very well, okay? And lastly, only one caretaker should give flecainide, because, again, if we just the other day, we had the patient on propranolol, and mom gave like 10 times the what I told her, the prescribed dose by mistake, of course. And then the baby was super fine, and we admitted him for a day or two, and then he went home without even doing anything. Versus if this had happened with flecainide, then we probably would have lost the patient or something. So flecainide is very dangerous if you made a mistake. So flecainide, respect flecainide. Only one mom or dad only should give the dose. Or both of them, but both need to be well aware of the dose and stuff. So flecainide, don't let anyone visiting that day to give the dose, okay? So flecainide, just respect and let the family knows this, okay? And then of course there are drug interaction with others, so be aware of this. Amio increases the flecainide, propranolol increases the flecainide, and it increases the digoxin, okay? So anyways, so when you're toxic with flecainide, the treatment is you have to alkalize, because acidosis, acidosis makes it more potent. And when you're toxic, you're very sick, you're probably acidotic. You want to alkalinize the patient. Sodium bicarb is a big one. TPN or lipids is also, had been used. Usually you may need to do on ECMO. Dialysis doesn't work. So ECMO is probably, if there's so much flecainide, ECMO is probably what will save the patient, okay? So that's why it's a big deal. Okay, last slide. We are almost out of time. Okay, so questions so far before the last slide?
Okay, sorry, Dr. Muhammad.
Yes.
Regarding the indication of use of flecainide, we can use in atrial fibrillation, okay?
Yeah.
No.
But there is different mechanism other than atrial flutter.
Yeah, flutter is different than fib. Fib is different, flutter, fib is completely different things, right? So fib is very, very rapid, chaotic atrial activity, like 450, very, very rapid, so it's different. So flecainide won't be able to slow the AFib such that the patient goes 1-to-1, okay? Very different, okay? Yes, so fib you can, flutter you cannot, okay?
Okay. Thank you.
Welcome. So last slide. Oh, sorry. I'm out. Here, okay. Last slide. Okay, so this is our you know, once I did a protocol for SVT, but no one had used it so far, which is, you know, I don't know why. But, you know, it was a little bit confusing. I get that. But let's just review it really quick. So, you know, when we have...
it's very small. It's very difficult
small.
to read.
Yeah, okay, I will try to read it out loud. Okay.
Okay.
So, when you have someone who you think is in regular SVT, meaning it's not atrial tachycardia, it's not flutter, it's usually, it's, you know, it's AVRT or AVNRT. You believe, based on ECG, based on what we said before, okay? This is what this guideline is for this specific patient, okay? Not for every SVT. Those that you believe it's straightforward, one AVRT or AVNRT, the commonest cause of SVT, okay? So, meaning they are regular, there's one-to-one, it looks reentrant, you know, sudden onset, sudden offset, you know, very typical looking. So this is the algorithm for. So usually they are very stable. Okay, so you go this route, it's very stable. So once they are when they present with tachycardia, you always ask yourself, is it short RP or long RP tachycardia? Okay, and we talked about this before, okay? Okay, so once you establish whether they are short RP or long RP, of course, you know, you establish this and then you give adenosine or do vagal maneuver and you hopefully terminate the tachycardia, okay? So if you give adenosine or do vagal and you terminate the tachycardia and it's short RP to begin with, you give propranolol. This is your drug of choice, okay? If in babies, in adults, not in adults, sorry, you know, 8 years and onwards when they are taking pills, atenolol is also good beta blocker, okay? So propranolol in babies, you know, liquid propranolol, tablet atenolol for older individuals. Of course, atenolol is BD, propranolol is usually Q6 in babies, and then 3 times a day in, you know, beyond 4 months of age or 6 months of age. So, so propranolol is very inconvenient. You know, TDS, it's not easy, trust me, okay? So atenolol is your better drug of choice. If someone, you know, you can also dissolve atenolol. There's also atenolol, you can also dissolve it. So I tend to give atenolol for older individuals, you know, 6, 7 years and onwards. And, you know, less than that, you know, I usually do propranolol, okay? So short RP, usually beta blocker is more than enough, usually. Of course, if there is recurrence, then you add digoxin or add flecainide, okay? Or switch propranolol or atenolol to sotalol, okay? So short RP usually is relatively easy to manage, okay? One drug is enough, beta blockers usually is enough, okay? If it's long RP, often many people start with flecainide because they, you know, beta blocker only with long RP usually doesn't work as good. So many people will start with flecainide as your #1 drug of choice if it's long RP. So you do flecainide and then you add, if there is recurrence, you add propranolol usually, okay? Or, you know, any beta blocker, okay? Depending on the age, of course, okay? And sometimes with long RP, it's very difficult to treat. You need to give 3 drugs like digoxin, flecainide, propranolol combination, or sotalol, digoxin, okay? Or, you know, sometimes many combinations. You know, I avoid giving amio, okay? So this is long RP. Long RP is usually more complex. And then one last thing, if you give adenosine and it terminates, but then resumes, so then when it terminates, it confirms your initial diagnosis, but it resumes, then you know this patient needs IV drug. So then you give IV esmolol, it's a very good short-acting beta blocker drug. And you give IV esmolol, and then wait for like half an hour, 40 minutes, and then give adenosine, and then hopefully with beta blocker on board, and adenosine, it will not come back, okay? So that's your initial algorithm that you need. You know, you don't have to call me with every SVT. If you follow this algorithm, no one would fault you. No one would tell you, why did you do that? Why did you do this? If you believe in your initial diagnosis and you follow this algorithm, you should be fine. And you most of the time.
One question.
Yeah.
One question. Now, if the SVT is not responding to adenosine, then you give esmolol and then do the challenge again with adenosine. That's what you said.
Yes, esmolol is very rapid acting. It's like in 3-5 minutes, you should see effect of esmolol. So it's very quick. So I usually wait 20 minutes, 30 minutes just in case. And you give, you give IV adenosine after esmolol is being on board, okay? And you can give, you can escalate beta blocker. You can give high doses, and people usually tolerate them fine, okay? So you usually, at least you do 200 mics per kilo per minute. Some people go to 300 mics per kilo per minute, or 400 or 350, So anyways, I wouldn't worry about the, how much beta blocker. Usually people tolerate it very, very well. And esmolol, what's good about esmolol, if blood pressure comes down, you stop it in 3 minutes, there's no esmolol in your system. It's really rapid, very short-acting beta blocker. So it's like turn on and off, switch, okay? So you can, taper it as you wish, okay? So, and sometimes you give also oral flecainide or IV flecainide, so you can give also, let's say esmolol doesn't stop it as well. You give flecainide, esmolol, and you give adenosine afterward, and usually it should stop, okay? Makes sense?
So for long RP, you don't give beta blockers as first line?
Well, many people don't. To be honest, sometimes depends, sometimes I do, sometimes I don't. But I know that in back of my mind, I think usually patients will require both drugs anyways. Usually a patient would require flecainide and a beta blocker. Usually, okay, but of course you try to give one drug and try, it's fine to start flecainide only initially and see what happens, but it would be very unlikely for beta blocker only to work, so that's why flecainide makes more sense to start, okay. Yes,
sorry, Dr. Mohammed, regarding Sumaya.
Yes,
regarding osmolol, most of the other hospitals, they don't have osmolol. So what
No, in our ICU we have. In our ICU we have.
No, our ICU or any other ICU, but in casualty or in most of the hospital, they don't have osmolol.
Is it?
Yeah. And
that's
sometimes
true.
in the middle of the night, they can't get it even.
Yeah, I think that's true. Of course, usually if an SVT doesn't stop with adenosine, usually we have to transfer the baby, I mean, unless you want to give amio. Everyone has amio. You can give amio instead, or transfer the baby, okay? So, I don't like giving amio, but if it's short, for a couple of days amio, and then we switch it to something else, that's fine as well, okay? But, amio, it's more, esmolol is way more benign than amio. Amio in babies especially could cause cardiovascular collapse. Some people die from IV amio in babies especially. So amio, if you're talking about baby, I avoid amio as much as I can. I'd rather shift the patient to our hospital. We give IV esmolol instead of giving IV amio somewhere, and patient may collapse there. Okay, if it's of course more like a older individual, then amio is mostly.
Yeah. Because that day when I called you, they don't have an osmolol. That patient with persistent SVT. They didn't have an osmolol at that time.
Yeah, because remember, amio is also calcium channel blocker, and we know that calcium channel blocker should not be given for babies. So, amio and very newborn, I don't like. I mean, you have to sometimes, but I don't like it. Okay. So transfer or yes.
For an emergency to shift to our ICU and treat with esmolol is one of the most difficult tasks at present.
You mean in Corona era, you mean, or what do you mean?
Before the Corona, it is so difficult to get the patient to our side and start off. Esmolol was the choice always for even Mustafa used to always advise us start off with esmolol, and then if you are not getting control. But at the present situation, it's and I don't see that it is going to solve this. So what is the other alternative?
Educate people, because we have to educate people about esmolol. People don't know it, so then they don't order it. They are not comfortable with. It's partly our fault. But and we'll try. I don't know. Dr. Adnan is here. Maybe he will have ideas. But esmolol is a very nice drug, and people should be aware of it and use it more and be comfortable with. And it's probably partly our fault that we're not educating people. Okay, and we'll work on this. Okay. Any other questions?
Excuse me, Dr. Mohammed, can I see that the previous, 4 slides, that fetal the treatment?
Yeah.
I just want to take a, yeah, that one, yes.
Yeah.
I just want to take a screenshot.
I can give it to you. It's fine. But this is, Dr. Mustafa, and now maybe Dr. Sundus, they have, I don't know exactly whether they follow this protocol. That's a protocol that I'm used to. But I know that they use digoxin and flecainide all the time, so I'm guessing they have similar protocol. I never actually spoke with them in general in terms of whether they have a specific protocol, but I think they probably followed something similar. Okay.
Thank
So
you.
don't, then it's fetal SVT. Usually you don't manage. It's usually Dr. Mustafa, right? So, so I wouldn't worry about this very much. Right? You guys are not involved.
Fetal
right?
SVT also comes to us when we are on call.
Really? Fetal
Yeah,
SVT?
Yeah.
What do you mean comes to us?
No, they will, when we are on call, they will call us. Only when Mustafa sees the fetal echo, he will be getting cases. No, otherwise, no. Everybody gets the fetal SVT.
Yeah. Okay.
But
So
not very common. Not very common.
Yeah, not very common. Okay. I think Dr. Mustafa does a great job of managing the patient, probably through, he speaks with the patient directly and stuff, because again, it's not very common to see, patients with fetal SVT.
Are you going to explain that fetal SVT slide or?
I will. It will be on YouTube. This.
Okay.
Yeah,
then. I'll look at that.
Okay. Questions? How many? I don't know how many people are attending. Let's see.
Generally, the numbers. This is written +6, isn't so? Or +6. If you toggle, in the lower part you can see +6.
Okay, that's because we had 15 at some point, but the people many people had issue with the internet speed, I think.
Yeah. The speed probably is on the lower side.
Yeah.
Dr. Muhammad.
Yes.
I am Mervat.
Yes.
For the Flecainide toxicity, what is the upper limit for this QRS widening?
Well, roughly, if by the way, Dr. Babu, there is 18 in the meeting, so that's good.
Is it 18? Huh? Because it's seen +6 here.
If I don't know. If the QRS is widened by like
30%, isn't so?
More, 20 to 30% more, then you should probably stop. That's your limit. Makes sense?
Yes, 20 to 30% of the regular one.
Yeah, of the initial.
It's very, very difficult to estimate. You want to magnify it by lens or something.
Yeah, you measure the baseline QRS. Let's say it was 60, and now it's more than 90. Then it's too much. Roughly. Yeah, especially we don't have blood levels. And then if you have way more, you have many other drugs. Don't play with fire. If you think that if there is definite widening, do something else. Add something else. Just don't play with fire. Okay.
Because the ECG you presented now is maybe 3 or 4 times the normal one. The one with widening, that's toxicity ECG.
Oh yeah, of course, yeah. That was toxicity. That was meaning someone was took like 10 times the usual dose for some reason, or someone became very acidotic because he was MPO, dehydrated or vomiting or sick.
With risk factor. So.
Yeah, that's unusual, of course. But if you gave the usual dose and the patient's super fine, it's very unusual to get toxicity from it. But sometimes mom by mistake give extra dose by mistake, And then if let's say mom tells you, I forgot to, I don't know, I'm not very sure whether I gave him the drug, then tell her, assume you already give it, you know, so then just wait for the next time. Don't tell her, if you're not sure, give it extra. You don't want to do this for similar reasons. Okay.
Okay. Thank you.
Okay. Any other questions? Dr. Mutwalli?
Yes. Only at the beginning, you were talking about pseudo WBW.
Yeah.
Yes, we said in adenosine test, in the usual WBW, there will be widening of the QRS. Correct?
Yes.
So
yes.
But this pseudo WBW, there will be no widening.
No, it will not change. Because you block, you block the AV node, you'll have AV block like usual, like as if there's no upstream pathway, you have AV block, or or you have, it depends what happens, but but usually, sometimes you don't have AV block, but if you have AV block, you'll just see AV block. Okay. If the patient became, let's say, bradycardia, then you will see bradycardia without widening of the QRS. If the patient became tachycardic, sinus tachycardia because of the adenosine effect, you will see similar QRS. The QRS should not change. Okay, if there is pseudo, the QRS will not change.
If it is not WBW.
Yeah.
Also, we receive a lot of calls about neonates born with dropped beats or maybe dropped beats, most probably.
Yeah.
It is something benign, we know, but is there any correlation between it and the newborn in the first few hours of age? This is very frequent, something like every week or.
Yeah. Newborns, they do have frequent PACs. That's very usual for newborns. And then, because of, you tell me why, it's probably because of sudden electrolyte changes, plus immaturity of the conduction system, or atrial myocytes. So it's very often, PACs do happen very often, and then some of them block, and then when they block, they reset the sinus, they usually reset the sinus node, and then the patient has bradycardia because of the blocked PACs. Of course, if it's usual, I try to ignore them. If they are, very frequent and patients bradycardic and having, issues from bradycardia, you have to treat this. And the drug of choice in this case is Flecainide, because Flecainide doesn't slow your sinus rate in general. So just, avoid those PACs, or like inhibit those PACs, and then you're good. If you give beta blocker, it also may work, but then it also causes further slowing of the sinus rate, and then you may, worsen the bradycardia, at least initially. So that's why in such cases, I go immediately on Flecainide rather than try beta blocker first. Yeah. But of course, try to avoid giving anything as much as you can.
Yes.
Yeah.
But if frequent PACs inducing bradycardia, at that time we will start.
Yeah, I usually do Flecainide. Yeah. Okay.
Okay. Thank you, Mohammed.
Okay, guys. Thank you.
Thank you, Mohammed.
Thank you.
Bye.